Good morning, everyone. I think in the interest of time, we'll go ahead and get started. This is scientific session. No, you can't hear me? Is this better? Okay, great. So good morning, everyone. In the interest of time, we'll go ahead and get started. This is scientific session number 2 for basic science. I am Dr. Jamie Robinson. I'm an assistant professor of pediatric surgery and biomedical informatics at Vanderbilt Children's Hospital in Nashville, Tennessee, and I will be moderating this session. And here's my co-moderator.
Good morning. Good morning. I'm Retta Berger. I'm a pediatric surgeon at Dartmouth Hitchcock in New Hampshire, Lebanon. And it's our honor to introduce our first speaker, Matthew Byrne from the University of Rochester in Rochester, New York, who's going to talk to us about GPR68 activation reduces postoperative abdominal adhesions in a murine pilot study. Morning.
Morning. Thank you. Thank you, Dr. Wilson, for the opportunity. I have no disclosures. Adhesive disease is a foundational problem in abdominal surgery. There's a multidisciplinary team at the University of Rochester that is investigating Ogeron's impact on fibrosis in multiple contexts. We want to prevent the vicious cycle of adhesive small bowel obstruction. We know that 2/3 of patients will develop adhesions after their first surgery, and overall 2.4% will present with adhesive small bowel obstruction. The highest incidence population is the pediatric surgical population at 4.2%. Our current understanding is macrophage migration to the site of injury, followed by a fibrin clot being laid down, and native fibroblasts migrating and differentiating into myofibroblasts, laying down collagen to form that mature adhesion. We hypothesize that Ogeron activation of GPR68 prevents this myofibroblast differentiation and halts the development of postoperative abdominal adhesions. Ogeron was discovered in 2015. Is an allosteric agonist of G protein coupled receptor 68. Our colleague found that Ogeron inhibited the TGF-beta-induced myofibroblast differentiation in a pulmonary fibrosis model, although the exact mechanism between GPR68 activation and myofibroblast differentiation is not understood. So we conducted a pilot blinded randomized trial of 20 black 6 mice. We used a validated right lower quadrant adhesion model, which included cecal abrasion, right lower quadrant abdominal wall abrasion, and 2 Stilk stitches in the abdominal wall. We treated with Ogeron or its vehicle on postoperative days 0 through 5. And in this model, mature adhesions are formed by postoperative day 10 when we harvested for gross and microscopic analysis. As you can see, we were successful in inducing small bowel obstruction. At harvest, we took clinical images of the peritoneal cavities of the mice and had 5 blinded pediatric surgeons score from 0 to 5 for adhesion severity. On the right, you can see this Ogeron-treated mouse received a score of 0, and on the left, this mouse received a score of 4 for planar adhesions and interloop adhesions. We found that Ogeron-treated mice had a significantly reduced clinical adhesion score. For this model, it's the most repeatable and validated in the literature. We next took formalin-fixed and paraffin-embedded slides, stained with H&E, and sought the site of highest fibrosis that was typically near the site of the silk stitch. We measured adhesion length and area, and note that this adhesion here is what we hypothesized would be something a surgeon would see in a single band obstruction event. We directly compared Ogeron and vehicle-treated mice and found a reduction in length and adhesion area, although only total adhesion area was statistically significant, and we believe this to be the more clinically relevant measure. So this pilot study shows that Ogeron successfully reduced adhesion formation in a validated murine model. We theorized that Ogeron activates GPR68, and that may limit TGF-beta-induced myofibroblast differentiation. Next, we're going to determine if Ogeron can reduce adhesions after the mature adhesions have formed. We're going to recapitulate the ex vivo experiments with pediatric surgical-derived peritoneal fibroblasts. And next, we're going to do further characterization of fibrosis by immunohistochemistry. Thank you, and I'll take any questions.
Fabian Doctor from Toronto. Congratulations for this study. I was wondering, have you looked at TGF-beta signaling in your adhesions, and if Ogeron modulates the canonical or non-canonical pathway of TGF-beta signaling?
So that's part of sort of the, we've gotten isolates from four. Thank you for the question. We have four patient-derived peritoneal fibroblasts, and I think that's where we'll be able to answer that question specifically ex vivo before we dive into it a little bit more in the mice. But that's certainly our next steps.
I have a quick question as well. Do you know if it's going to interfere with healing processes? Because you have to find that right balance between the adhesion that we all dislike, but you don't want an anastomotic leak, or so you want the bowel to heal, but prevent the adhesions. Do you know if the Ojerind is interfering with any other healing processes?
So we've done about 60 mice so far. We're just presenting on 20 of these mice. We've had one hernia. I think, as we transition to more clinically relevant sort of phase 1 parts, if Ojerind gets there, it will mimic Seprafilm and kind of the process that Seprafilm went through. With fibroblasts, we need them for healing the anastomosis and in the abdominal wall. We're kind of hoping that there's a sweet spot that can be treated with those native fibroblasts that migrate and just preventing that myofibroblast differentiation in the peritoneal cavity.
Hey, Mitchell Ladd from Wake Forest. That was one of my questions, Dr. Barzinger. But the other one is, this is a problem that's plagued us for a long time. People have looked at it for 100 years. I think, do you think that this one inhibitor will be the solution, or do you think it's going to be multifactorial? To me, it seems like a very big environmental problem and not just like one pathway.
Absolutely. I think the sort of next steps are the macrophage migration. Back in 2021, they saw a lot of GATA6 signaling with macrophages as a possible localizer. I think there's CCR2, CCR1 treatment that are available in the kind of the oncologic space that could be a combined treatment, doing a macrophage and a myofibroblast differentiation process. But I totally agree with you. We could have found, the golden bullet to take care of this problem, but likely it would be a multifactorial thing.
As far as the dosing, do bigger surgeries need more Ojerind and an API that's laparoscopic, almost a few drops? Do you plan to study like the localized versus general application in peritoneal cavity?
I think that thank you. I think that question can be answered both in like how intensive a surgery we do with the mice. So we're just doing gentle sequelibration with sandpaper, and that might cause a small local, area of inflammation. But say we have a perforation, I think studying that in mice first to see if there's a dose response for severity of intra-abdominal pathology.
And one question I had was, it seems like you did injections over the course of 5 days. Have you looked at all at what the results would be if you did just a single installation at the time of the initial operation? Because obviously we're not going to continue instilling this in our patient over the course of 5 days.
It's a great question. And I think, the use case down the road would be that at the very end of surgery, you have a solution, you swish it in the peritoneum, and you move on. I think that's something that as we kind of get into larger models or more severe models, that would be something that we'll have to look at.
I'll ask you 2 more questions. One is, usually our peritoneal cavity is infected, inflamed. Does Ojerind interact with defense against infections? And the other thing is, when we operate in the pelvis that can have a lot of adhesions, how do you think your molecule will interfere with fallopian tube motility for down the road fertility in these young girls?
I will say Ojerind being discovered in 2015, there's only been 8 publications so far on the molecule itself. It's a very exciting kind of space to be in. There is implications in T cells. There's implications in neurocrest-derived cells. I think there's a lot of work that needs to be done to see exactly how individual cells are impacted by Ojerind.
Thank you. Great work. Can I ask you to turn our monitor on so we don't get too much neck pain looking around? So, thank you.
Thank you.
We can't see on the monitor down there.
All right, great. For our next presentation, we have Ms. Felicia Balsamo, a master's student from the Hospital for Sick Children, who will be presenting on argon inhalation, a novel treatment for experimental necrotizing enterocolitis.
Thank you for the opportunity today to present our work on argon inhalation as a novel therapeutic for experimental neck. Do I just click? Do I The slide here? Okay. I have nothing to disclose. Necrotizing enterocolitis is a severe intestinal inflammatory disease frequently affecting premature neonates, and despite advances in research and clinical care, it continues to be a high cause of morbidity and mortality in these neonates, and that's why there is a need for therapeutic innovations. Now, importantly, neonates with NEC are commonly mechanically ventilated, and in our center, we have found that patients with medical NEC are 89% ventilated, and those with surgical NEC are 100% ventilated. So this allows for the opportunity for the investigation of a therapeutic inhalational strategy in these populations. Inhalation has been around for around 2,000 years, mainly to employ medicine directly into the airways, into the lungs. But with advances in research, this now extends to other organs as well. And key advantages of the inhalational therapy, particularly for gases, can be the rapid distribution, the predictability, quick reversibility, and increased bioavailability throughout the body. And important to note, nitric oxide is currently in use in clinic for other neonatal conditions. So therefore, delivery of an inhalational compound in the respiratory circuit of ventilated neonates with NEC is both practical and can be achieved clinically. Now, noble gas therapy has been an increased surge in interest, as noble gases are chemically inert in the therapeutic realm. They have clinically useful biological effects. And specifically in the literature, there has been a lot of investigations into xenon's neurocardio and nephroprotective properties, but this gas is less abundant and can be extremely costly. That's why studies have gravitated more towards the use of argon, being the more abundant and less costly option, and mainly in vitro and in vivo studies support cardio and neuroprotection, and mechanistically, they have shown it to have anti-inflammatory, anti-apoptotic, and anti-ischemic properties. However, there have been no studies on argon inhalation in neonates, and is specifically also in necrotizing enterocolitis. And of the studies that are available, preclinical and adult clinical studies, there have been shown no adverse or toxic effects on hemodynamics, respiration, and liver and kidney function. And recently, we have published a paper showing the safety of argon in a neonatal mouse model. We are the first to show this. And this was in a sepsis neonatal mouse model. And this is just showing that it is feasible and safe to give argon in this model. Therefore, the aim of this study is to evaluate argon inhalation as a novel treatment strategy in experimental NEC. Now, using a well-established method in our lab, NEC was induced in C57 Black 6 pup mice on postnatal days 5 through postnatal day 9 through hyperosmolar gavage feeding of formula, as well as LPS and intermittent hypoxia daily. And then distal ileal tissue was harvested at P9. Now, argon was administered from P6 through P8, with a 70% argon to 30% oxygen concentration, and this argon tank was connected to a sealable chamber housed within an incubator to control for any hypothermic conditions within these pup mice. We have shown first that argon inhalation promotes weight gain during experimental NEC. So during the NEC induction period, we find that NEC pups are unable to maintain weight, even lose weight. And when argon is administered to these pups, we see that they are able to maintain, even gain weight in the last day of the NEC induction period. And looking at H&E staining of these distal ileal tissues, we found that NEC-induced intestinal injury is reversed after argon administration. Through histopathological scoring with blinded investigators, they gave NEC grades, tissue showing NEC with a score of 2 and above. And we show that with NEC, there's 2 levels of 2 and 3, which is histopathological of NEC. And when these pups are exposed to argon, we have decreased levels of injury. We also show that argon administration attenuates intestinal inflammation during experimental NEC, shown by gene expression analysis of TNF-alpha and IL-6, those pro-inflammatory mucosal markers, when these NEC pups are exposed to argon. And also, TLR4 signaling is a hallmark of NEC pathophysiology, and this is why we wanted to look at TLR4 in the context of argon, as literature has shown that argon can function through TLR4 modulation. So we looked at gene expression analysis of TLR4 and its downstream mediators MID88 and TRIF, and found that they are increased in the NEC group and then significantly decreased when the NEC pups are exposed to argon. So in summary, argon inhalation during experimental NEC can promote weight gain. It reverses NEC-induced intestinal damage and mucosal inflammation, all modulated by TLR4 signaling in the intestine. Now, argon inhalation is a novel and practical therapeutic intervention, and it can be the first step towards a paradigm shift in the treatment and outcomes of neonates with NEC. Argon can be easily introduced in the respiratory circuit of these ventilated preterm neonates with NEC. Lastly, I'd just like to acknowledge all members of my lab, as well as funding agencies, and I open the floor to any questions.
Hi, I'm Gail Vesner from Nationwide Children's Hospital. Congratulations on a really lovely study and so well presented. So am I correct that in your experimental timeline, this is prophylactic therapy? Have you ever induced NEC and then tried to rescue any pups once they already had NEC? Great talk. Thank you.
Thank you for the question. Yes, so within our next induction period, we start on P5, goes to P9, and we administer the argon from P6 through P8. So that's when injury is already established and therefore increasing throughout the period. So we haven't done the late stage of giving the argon and see if it can completely rescue and reverse the damage. And we also haven't tried the more early stages as well as giving the argon. So we have that more therapeutic, but still within the time frame where injury is established and continuing to increase. Yes.
I think this is a very interesting study because it's a problem that we deal with so frequently. One question I have just from a feasibility standpoint is the introduction of argon into the oxygen circuit in neonates. What exactly does that look like? Is it similar to the use of nitrous oxide? And what effects would it have on the oxygen administration that we're typically trying to provide in these very sick neonates?
Yeah, so I think that's why it's clinically feasible to give the argon. As you said, nitric oxide is already established. So I think the system would be very similar. And there's also use of the new Anaconda gas administration, which could also be implemented in this context. And in terms of your second point was that oxygen levels, I know that some babies can be 100% oxygen given. So we have to also in the future test for different levels and concentrations of argon to see where it is still effective. If 70% is the main dose, then it might be troublesome to also give high levels of oxygen. So we want to see if we can also lower argon concentrations and get the same effect, therapeutic effect. So that's in the future plans, yeah.
Could I just ask a quick question, Paul Ostliver from Bangkok? What's the mechanism of the weight gain? Is that edema? Or what do you think is the reason that the pups gain weight, and is that a good thing, or could that be something of concern?
Yeah.
It's very interesting paper.
Thank you for your question. It could have an effect on maybe metabolics or increased possibility of absorption of nutrients. So there's less intestinal injury. So maybe these pups are able to actually properly absorb the nutrients the way that they're supposed to in the ileum tissue. So this is why it allows for either maintenance of weight or weight gain. So that's one possibility, but something that we definitely should look into in the future. Yeah.
Thank you.
Thank you so much.
Thank you very much. Great work. Our next speaker is Dr. Deuce from Hopkins, who is going to talk to us about colonizing mouse intestine with a multi-strain probiotic, promotes gastrointestinal motility and decreases inflammation in necrotizing enterocolitis.
So, dear chairpersons, ladies and gentlemen, I'm presenting on behalf of my colleague, Ms. Daphne Clark, who can't be here today. We have nothing to disclose. So, necrotizing enterocolitis is a serious gastrointestinal disease characterized by inflammation, ischemia, and necrosis of the intestine. The exact causes are still unknown, but the main risk factors are maturity, prematurity, administration of formula feeds, and changes in the gut microbiome. We've also shown that the activation of toll-like receptor 4, TLR4, the receptor for gram-negative microbes on the intestinal epithelium, is required in the pathogenesis of NEC, leading to increased apoptosis, necroptosis, and reduced epithelial proliferation and migration. Breast milk has been known to be protective and to prevent TLR4 signaling. We've also previously demonstrated that dysmotility precedes the inflammation in necrotizing enterocolitis in mouse and piglet models mediated through TLR4 signaling. And besides breast milk, the administration of probiotics have also been considered to be another potential strategy to prevent necrotizing enterocolitis in premature infants. However, this therapeutic approach has caused significant controversy. For example, last October, the FDA issued a warning on the unauthorized use of probiotics after a case of probiotic sepsis, causing the most common probiotics to be discontinued. But we hypothesized that the colonization of the premature intestine with a multi-strain probiotic can prevent NEC in mice by decreasing intestinal inflammation and promoting gastrointestinal motility. So from P3 on, mice in the probiotic group were fed a formula containing a multi-strain probiotic with Bifidobacterium infantis, lactis, and Streptococcus thermophilus. And from P8 onwards, NEC was induced through 4 days of formula gavage with stool from an infant with severe NEC and intermittent hypoxia twice daily. So H&E staining and immunohistochemistry showed a reduced inflammation following the administration of probiotics, and also PCR showed reduced expression levels of pro-inflammatory cytokines. We also investigated the probiotic administration in vitro using the NF-κB translocation assay. So the administration of NEC bacteria caused an NF-κB translocation to the nucleus, as shown by increase in the fluorescent intensity compared to the controls. Probiotics alone did not have an effect. However, the administration of probiotics to NEC bacteria had an inhibitory effect on NF-κB translocation. And these findings were quantified and confirmed by PCR signaling. Intestinal motility was measured by oral administration of a fluorescent tracer 30 minutes before sacrifice, and several sections from the stomach to the cecum were divided into 1 centimeter sections to measure motility as a function of the geometric center. And the administration of a multistrain probiotic promotes small intestinal motility at baseline in breastfed pups and restored intestinal motility to baseline following the induction of NEC. And we also wanted to investigate if probiotic administration could alter the DNA methylation status of the intestinal epithelium. Therefore, we performed a methylation assay. So DNA methylation is an epigenetic mechanism that can cause changes following environmental stimuli and regulate gene expression. So the administration of probiotics alone already altered the methylation status in the intestinal epithelium, as seen here in Figure A. Figure B shows differentially methylated sites in NEC versus control. However, the methylation pattern seen in NEC plus probiotics versus control resembled the pattern seen in control plus probiotics versus control, more than that seen in Figure B, suggesting a decrease in the number of changes in the DNA methylation induced by NEC. The chairpersons, ladies and gentlemen, the administration of a multistrain probiotic in mice may prevent the development of NEC in part by restoring gastrointestinal motility and decreasing intestinal inflammation. Probiotic administration induces significant epigenetic changes in the intestinal epithelium at baseline, but may decrease the number of changes in DNA methylation induced by NEC. On behalf of my colleague, Ms. Clerk, thank you very much to everyone at the HACM Lab.
Okay, good morning. Kathy Hunter, Oklahoma. Very elegant data. Always enjoy seeing what comes out of the HACM Lab. One of the things I thought was interesting is so when you're inducing NEC in these mice, you're introducing a slurry of fecal materia. Is it from a single patient or from multiple patients?
It's from one patient.
From one
That's it,
patient.
From one patient.
So have you characterized the microbiome in that particular slurry? And also, have you considered comparing different slurries from different patients with NEC? Because obviously the signature is perhaps slightly different, even though we know there'll be a tendency to Enterobacteriaceae, and seeing if your combination of probiotics is efficacious amongst different patient groups.
Thank you very much. It's a very good point. Yeah. So we only used the NEC bacteria from one patient now, but that's definitely, because it's an ongoing study, that's definitely on the plan because we have multiple patients. We have to investigate the effects of probiotics, which could be different. Thank you.
Hello, Agostino Pierro, Toronto. First of all, congratulations. This is an excellent study, and congratulations to your group and Dr. Hackham as well. I would like to ask you about the relationship between inflammation and motility, because you are concluding that by giving these probiotics, you affect the development of NEC by this reduced inflammation and increasing motility. What do you think is the relationship between the two? You actually get less inflammation in the gut because you get more motility of the gut preserved, or the other way around?
Thank you very much, Professor Pierre. Yes, the first one. So we think that this motility precedes the inflammatory process during during the development of necrotizing enterocolitis. It's a kind of, assumption, prevention of NEC.
And why so? What is the evidence to support the concept?
So what we see in previous papers, when we check the TIS motility, so TIS motility we at different time courses, and we had an improvement in the motility before the full picture of NEC. So that's why we assumed this motility could.
Okay, thank you very much. Very interesting. Congratulations.
Thank you. In the interest of time, we'll move to the next speaker. Great work. Thank you.
Our next speaker will be Dr. Moskowitsova from Boston Children's Hospital, who will be presenting transamniotic delivery of coagulation factor 8 mRNA, a potential novel strategy for the perinatal management of hemophilia A. Thank you.
Good morning, and thank you for the opportunity to present our work. We have no disclosures. Procoagulant factor 8 plays an essential role in the intrinsic pathway of the coagulation cascade. It is a large protein consisting of multiple domains produced by liver sinusoidal cells and endothelial cells outside the liver throughout the body to eventually be released into the bloodstream. Once the damage to the blood vessel occurs, factor 8 is activated. A mutation in a gene coding for factor 8 causes hemophilia A. This is X-linked monogenic disease and one of the most common causes of inherited bleeding disorders. Current standard of care is based upon administration of costly and very short-lived factor A concentrates, either as prophylaxis or on-demand treatment. Infants with hemophilia A are at increased risk of intracranial hemorrhage and other potentially severe and life-changing bleeding complications, especially during birth. The previously mentioned current treatment strategies are very limited and only available postnatally. No prenatal therapy for hemophilia A is currently offered. mRNA therapies have emerged experimentally as a powerful alternative for factor 8 replacement and effectively prevented bleeding in adult hemophilia mice following IV delivery. 2 years ago, here at APSA, we have shown that encapsulated mRNA injected intraamniotically can traffic via the amnioplacental interface to the fetal circulation, besides being simply swallowed and aspirated, establishing an effective, minimally invasive strategy of fetal mRNA delivery for protein replacement at multiple anatomical sites. In this study, we sought to determine whether exogenous encapsulated factor 8 mRNA so delivered could be incorporated and translated by the fetus, leading to the presence of factor 8 in the fetal circulation. A custom-made human factor 8 mRNA was commercially obtained. The final sequence consisted of 7,056 nucleotides and included proprietary sequence optimization with nucleotide substitution, 5' cap1 addition, and 3' elongation with poly-A tail to eventually enhance mRNA stability, translational efficiency, and to decrease mRNA immunogenicity. To minimize degradation following delivery in vivo, the mRNA was encapsulated by self-assembling lipid and polymer into lipopolyplex. The degree of encapsulation into lipopolyplex was measured by fluorescence assay. After that, rat fetuses were divided into two groups, on gestational day 17 or E17, with term being E21. One group underwent intraamniotic injection of encapsulated human factor VIII mRNA in all their fetuses, while the other group received lipopolyplexes only, with no mRNA. The control group was necessary to control for interspecies homology of factor VIII protein, as amino acid sequence between human and rat for factor VIII overlap with up to 76% of homology. Following intraamniotic injection, at daily time points until term, fetal liver and sera were analyzed for the presence of human factor VIII by ELISA. The encapsulation rate of factor VIII mRNA into lipopolyplex was 97.1%, which was comparable to what we and others have previously reported for other mRNA products in the same composite. Overall fetal survival between fetuses receiving factor VIII mRNA and controls was about 87% and not statistically different. There was no maternal mortality and no premature labor in any group. When controlled by mRNA-free injections, fetal serum human factor VIII levels were significantly higher overall in mRNA group, peaking at E20. ELISA was positive in the samples from the control groups, confirming some degree of human-rat homology for factor VIII. On the other hand, overall fetal liver human factor VIII levels were not statistically different between the groups. There was variability in significant differences between the groups at the different time points, which further confirmed interspecies homology, particularly manifesting at this anatomical site. In conclusion, exogenous encapsulated mRNA encoding for human procoagulation factor VIII appears to be incorporated and translated by the fetus following simple intraamniotic delivery in a healthy rat model. Topographic mapping of mRNA incorporation and translation remains to be determined in a model with minimal to no human homology. However, transamniotic nucleic acid therapy could become a novel strategy for perinatal management of hemophilia A. I'm grateful to all my co-authors and to all of you for your attentions, and I'm happy to take any questions.
Paper is open for discussion.
Fabian Doctor from Toronto, fantastic presentation. I was wondering if you tried to also use this therapy in the hemophilia A knockout mouse.
Yeah, we are this is initial studies for hemophilia A, and we wanted to sort of like place a baseline for if it's even possible to deliver mRNA with coding for factor VIII, especially given that this mRNA is especially long sequence compared to any other mRNA that we previously injected. As I mentioned, it was 7,000 nucleotide, the sequence of the mRNA. All the experiments we are doing in our labs, we are focusing in the rat models and rat transamniotic therapies, especially as rat model is a little bit more closer to the human translation than mouse. So to answer your question, simply we have not tried it in a mouse model or any disease model yet. However, there is one disease model for rat that we are planning to eventually potentially try our transamniotic delivery of mRNA in. However, we were interested initially to just simply playing a base ground.
We got two questions. Does factor VIII cross the amniotic barrier or the placental barrier in humans? You know that. And two, you showed that after treatment with your mRNA in your ELISA, you had the control, which did not get human factor VIII mRNA, and the ones who did had the same amount of factor VIII delivery or in the serum. how close did you realize that cross-reacting between human and rat factor VIII?
Exactly because of this that we are seeing a lot of positivity in control group, and it's ELISA checking for human protein. So obviously, rat not getting any mRNA of human shouldn't have any positivity. It's just showing that there is that homology that is up to 76%, which we are aware of. That's why it's important to have a control group in at every time point. Especially in the liver, what we are thinking why this homology is more significant is not only that there is the homology, but also for ELISA, tissue that has a lot of blood contamination is more likely to give positivity, false positivity in the results. And even though we try to wash all the livers, there's in native liver, they just contain a lot of hemoglobin. And even with the gestation of the rats, the hematopoiesis increases in the liver throughout gestation, so that probably contributed to it as well.
I'm sorry, in the interest of time, we'll have to move on. Thank you.
Thank you. Our next speaker is Dr. Mahmoud El-Basiri from Johns Hopkins, who's going to talk to us about traumatic brain injuries induces gastrointestinal inflammation and ileal dysmotility due to the alteration in the neuroendocrine system and CCR2 dependent pathway.
Thank you for the opportunity to present our work. I have nothing to disclose. So as you may be all aware, TBI is a public health issue in the US, with around 190 Americans dying each day from TBI-related injuries. And although there has been lots of research and million-dollar investments, we still lack FDA-approved drugs to manage this complex disease. And clinical trials and treatments keep failing. So one of the major reasons why TBI treatments keep failing is that TBI is a systemic disease. And as you can see here, TBI impacts various peripheral organs, such as the lungs, the gut, the liver, and the kidneys. And nowadays, the gut is recognized as a key player in the pathogenesis of TBI through brain-gut axis dysfunction. And many clinical studies have shown that TBI patients experience feeding intolerance, gastroparesis, and ileus within the first week after injury. And this is mainly due to changes in the microbiome as well as an altered barrier permeability, which allows the translocation of the pathogenic bacteria into the systemic circulation. And then this can predispose the patients to higher rates of sepsis and worse cognitive outcomes. So the main goal of our research is to better understand the pathologic changes that takes place in the gut, with the ultimate goal of reversing this hyperinflammatory vicious cycle and improving cognitive outcomes. So when it comes to animal work, we have recently shown in our published paper that traumatic brain injury induces intestinal dysmotility and inflammation in mice acutely after injury. As you can see here, using the FITC-dextran motility assays, our results showed an impaired passage of FITC-dextran along the GI tract, as well as an increase in the inflammatory profile in the gut 3 days post-TBI, as depicted by an increase in TNF, interleukin-1 beta, and lipocalin-2. So our hypothesis was that TBI induces intestinal dysmotility and inflammation through various complex pathways, which include first an increase in gut inflammatory macrophages, second the activation of the enteric glial cells, and finally a reduction in gut serotonin synthesis. So to induce TBI, we used the control cortical impact model over the left parietal lobe, and then mice were euthanized on days 1 and 3 to harvest the ileum and study its function. To start with, we utilized flow cytometry to quantify immune cellular infiltration, and as you can see here, our results showed that after TBI, there was an upregulation in the populations of pro-inflammatory macrophages. And then to better understand this, we stained ileal tissues with IBA1, which is a global marker for macrophages. And as you can see in the lower panels, after TBI, there was a significant increase in the expression of IBA1. And to better understand the role of macrophages in modulating intestinal inflammation, we used genetically modified CCR2 knockout mice, which lack the CCR2 surface receptor and exhibit defective monocyte infiltration into the gut. So in these mice, we showed that the inflammatory process is downregulated as depicted by a reduction in the inflammatory cytokines, again, lipocalin-2, TNF, and interleukin-1 beta. We then shifted our focus to the enteric glial cells, which are crucial cells of the enteric nervous system, and these cells have been shown to regulate the gut's motility by secreting various neurotrophic compounds such as GDNF and BDNF. And to study the function of these cells, we stained ileal tissues with GFAP, which is a global marker for enteric glial cells activation. And also, as you can see in the lower panel, after TBI, there was an increase in GFAP reactivity in the muscularis externa layer of the gut, as well as a downregulation in the production of neurotrophic factors by these cells, such as GDNF and BDNF. And finally, we were interested in studying the role of the enteroendocrine cells. So these are specialized cells that line the intestinal epithelium, and they form the largest endocrine system in the body. They produce various anti-inflammatory hormones, such as GLP-1, serotonin, and ghrelin. And to study the function of these cells, we also stained the ileal tissues with chromogranin A, which is the major marker for these cells. And after TBI, there was a downregulation in the number of these cells. We've then stained the same tissues with chromogranin A and serotonin to study serotonin production. And as you can see here, 3 days after TBI, there was a significant reduction in the number of the cells as well as the intensity of serotonin. So in conclusion, TBI leads to intestinal dysmotility and inflammation through various complex pathways, which include first the activation of the macrophages and the release of pro-inflammatory cytokines by these macrophages, as well as the enteric glial cells activation, which could result in an impaired motility, and finally, a downregulation in the production of serotonin by the enteroendocrine cells. So our current focus in the lab is restoring serotonin signaling with the prokinetic agent prucalopride, which binds to the 5-HT4 receptor agonists in the gut. And in our prelim data, we have recently shown a downregulation in the inflammatory markers in the brain after administering this prucalopride for 3 days after TBI. Our lab has also developed a novel technique to stimulate the vagus nerve non-invasively by attaching electrodes to the ear of the mice. So this technique will help us better understand the communication between the brain and the gut. Finally, I want to thank Drs. Nasser and Hakim and everyone in the lab who contributed to this work. Thank you.
Augusto.
Augusto Zani, SickKids Toronto. Beautiful paper. It's like the reverse of what, of course, Dr. Hakim has been studying for years, coming from NEC, and of course, the impact on the brain. Now, instead, it's the impact on the brain, of the brain on the gut.
Mm-hmm.
But I'm wondering whether you looked at other organs. You, of course, mentioned the increased number of macrophages in the intestine. And so I'm wondering whether also other organs have an enrichment with macrophages, and whether this is just an association. So there's TBI, and then there's an inflammatory reaction all over the body, or instead there is something that happens signaling through the brain-gut axis.
That's a great question. So currently we're looking into the colon to also see the changes of the macrophages, and we've also collected the spleen to see if there are major changes in the immune cells. And this is our plan for this project. Thank you for the question.
Sorry, great work. Did you look at denervation as well? Is it a neuronal impact as well? And what happens if you have less severe brain injury? Is the inflammation less? What happens at the level of the spinal cord injury? Does it change depending on the level, and are different levels of the intestines involved?
Actually, we haven't looked into that. The brain model we use is a moderate to severe injury, and we haven't looked into the spinal cord. But now we're trying to look the other way around. So we're reversing the gut inflammation by providing the serotonin agonist, by providing vagus nerve stimulation. And currently we're looking at the brain, what happens to the brain and the gut at the same time. Thank you.
Great. There are no any other questions. Thank you very much.
Thank you.
Great paper.
Our next presenter will be Dr. Zaini Ruttenstock from the Hospital for Sick Children, who will be presenting transcriptomic analysis of inflamed rat. Fetal gastroschisis intestine reveals altered homeostasis that can be reversed by stem cell extracellular vesicle administration. Thank you.
Thank you very much. We have nothing to disclose. Gastroschisis still offers a significant source of prenatal morbidity, with 20% of patients having complex gastroschisis and a third of them developing short bowel syndrome. But what causes all of this? Well, the high morbidity in utero is mainly due to the bowel exposure to the amniotic fluid, inducing various degrees of inflammation. Once the baby is born, there is no effective treatment to reverse this inflammatory damage. Amnio exchange has been studied as an intervention but has never been really adopted because of its unproven benefits. But the key message from the randomized trial recently conducted in France was that all efforts should be made towards decreasing the bowel inflammation in utero. We and other groups have reported that the amniotic fluid stem cells and their derivatives have regenerative effects on various models of neonatal intestinal inflammation. In our lab, we have been studying extracellular vesicles derived from amniotic fluid stem cells that are biological nanoparticles important and responsible for the paracrine mechanism of action. We have previously shown that in an experimental model of gastroschisis, the intestine undergoes an activation of an inflammasome cascade, which can be reversed by antenatal administration of AFSC-EVs. So the aim of our present study was to analyze architectural and transcriptomic changes in the intestine of fetal rats with gastroschisis, and to assess the regenerative effects of AFSC-EVs antenatal administration on gastroschisis bowel. The AFSC-EVs were isolated from conditioned medium via ultracentrifugation and were characterized for size, morphology, and canonical EV protein markers. We established a model of gastroschisis whereby an abdominal wall defect was surgically created on embryonic day 18, and the fetal pups also received intraamniotic injection of idasaline or AFSC-EVs. Pups that were not undergoing any surgery served as controls. On E21, the intestines were harvested and investigated for EV tracking studies, intestinal architectural changes, and transcriptomic analysis. First, we confirmed that fluorescently labeled EVs that were intraamniotically injected were actually really able to reach the gut. Then we found that the intestine of fetuses that had gastroschisis were significantly thicker than controls, whereas gastroschisis intestine treated with EVs showed less thickening. Looking at our transcriptomic analysis, we found 76 genes with the following gene expression pattern: low in control, high in gastroschisis, and low in gastroschisis treated with EVs. And we found that these 76 genes were predominantly annotated to biological pathways such as inflammatory processes, autophagy, and immunomodulation. In particular, gastroschisis pups showed an increase in expression of genes involved in response to wounding, response to stress, and response to inflammation, such as Lynch1, which is a key marker of the inflammasome cascade. Conversely, gastroschisis treated with EVs showed a decrease in genes that were involved in negative regulation of wound healing or negative regulation of stress response, such as CLN3, which is a gene involved in adaptation to cellular stress. We also looked at the opposite gene expression pattern, so high in control, low in gastroschisis, and high in gastroschisis treated with EVs. And we found 56 differentially expressed genes that, again, were predominantly involved in inflammatory processes, macrophage polarization, and intestinal barrier regulation. Gastroschisis pups had a decrease in genes that were involved in negative regulation of macrophage cytokine production, as well as negative regulation of interleukin-10 production, such as EPX. And in contrary, pups that had gastroschisis and were treated with EVs showed an increase in expression in genes that were involved in anatomical structural development, chemotaxis, and autophagy regulation, such as LAMA5, which is an intestinal stem cell niche gene. So in conclusion, we demonstrated that architectural changes to the fetal bowel in gastroschisis are associated with predominantly pro-inflammatory and immune responses at a transcriptional level. In vivo administered EFSC EVs reach the fetal bowel and restore intercellular homeostasis. But how is this relevant? How are these experimental results in a rodent model relevant for the human condition? I'm sure you're all aware of this seminal collaborative work demonstrating the feasibility of intrauterine repair of gastroschisis in a fetal lamb model. And we believe that this approach will be a reality in the near future. Please bear in mind that AFC EVs are a paradigm for theranostics. So we envision that EVs could be used in this approach as one, biomarkers to guide and select patients for the approach, as well as therapeutic agents applied topically in combination with phytoscopy to harness their anti-inflammatory and regenerative effects. Thank you very much.
In the interest of time, we'll move on, but please find Dr. Zani Ruttenstack at the end of the talk for any questions. Thank you very much.
Our next paper is presented by Dr. Manohar from the Markle Lab. The title of her presentation is Exploring the Therapeutic Potential of IL-17A Inhibitors in Necrotizing Enterocolitis.
Hey, we're good. Thank you for the opportunity to present. As we know, necrotizing enterocolitis is a devastating condition that affects primarily premature infants and is characterized by a multifactorial etiology, such as an immature intestine and immune system, formula feeding, and microbial dysbiosis. The devastating part of this is that it can also lead to downstream complications, including intestinal malabsorption, short gut syndrome, neurodevelopmental impairment, and chronic lung disease. NEC has been, in prior literature, shown to be a Th17-mediated disease, and several animal studies as well as human studies have shown that this disease is characterized by Th17-mediated cytokines as well as genes. And so we've known that not only Th17, but its primary cytokine, IL-17A, is implicated in NEC, but also implicated in inflammatory lung disease, and also in neurodegeneration and neuroinflammation and other conditions. The theory is that in NEC, IL-6, TNF-alpha, and IL-1 beta acute phase cytokines are released by intestinal inflammation and subsequent necrosis. This leads to an imbalance in the T regulatory and Th17 axis, with a pathogenic increase in Th17 cells, resulting in the secretion of IL-17A and IL-33, which are Th17-mediated cytokines. This results in a feedback loop that further increases IL-6, TNF-alpha, and IL-1 beta, those acute phase reactants. And so in our lab, we wanted to see if IL-17A inhibitors could be used to treat not only NEC, but downstream complications of NEC. And so we started off by first looking at human tissue, We're fortunate to have a human biorepository, and so we used infants with active NEC, as well as those matched infants that had been recovered from NEC, where tissue was collected at an ostomy takedown. And so we started off by doing a Th17 ELISA-based multiplex, followed by RT-PCR looking at key genes in the IL-17A pathway. And so we'll start off by looking at some histology. On the left, you have active NEC, and we see dysregulation of the intestinal architecture. And on the right, we have those same infants later on down the road after having an ostomy takedown after NEC, and we see recovery of that intestinal architecture. Now, when we look at those acute phase cytokines, we see that overall, they don't remain elevated when these infants recover from NEC, and there's a significant decrease in IL-6, IL-1 beta, and TNF-alpha, which is what we expect. However, interestingly, Th17-based cytokines remain elevated. And so IL-17A and IL-33 specifically show no significant downregulation, and IL-33 was in fact elevated in recovered NEC. So then we looked at PCR and gene expression, and we'll focus on 3 genes. CXCL8 is a marker of acute inflammation and neutrophil recruitment, and we see a significant decrease in CXCL8 in the recovered NEC group, which is what we expect. However, again, interestingly, there's no decrease in IL-17A or IL-17 receptor A expression, indicating that these genes might be important to consider for the chronic pathogenic sequelae that is characteristic of NEC and those that recover from NEC. And so to further go along with this story, we wanted to look at IL-17A inhibition in vivo. And so using our standard murine model of NEC with gavage formula feeds with LPS, hypoxia, and hypothermia, it's a 5-day model, and we treated these mice with daily intraperitoneal injections with an IL-17A inhibitor. And so first off, we were just trying to show that the mice would tolerate IL-17A inhibition. And overall, we see that not only did they tolerate it, but they actually did pretty well. And so we see a decrease in overall clinical sickness scores, as well as macroscopic and histological injury. And so the top panels represent representative images of the intestine with the breastfed control on the left, the NEC and the vehicle control with an IgG antibody in the middle, showing disrupted intestinal architecture, and then the NEC plus IL-17A inhibition on the far right. We also wanted to look at acute brain injury as an early looking at neurodevelopmental impairment, and we also saw that IL-17A inhibition prevented acute brain injury. So just a quick review of what we looked at. We specifically focused on microglia, which are the macrophages of the brain. And activated microglia are characterized by increased lecconarity, which means that they're irregular, decreased spread, and they're more amoeboid in shape. Resting microglia, however, have decreased lecconarity, increased spread, and are characterized by a circular body with increased branched processes. And so in our mice, we see that overall, the NEC mice have increased lecconarity or are more irregular and decreased spread, while our breastfed controls and our IL-17A inhibitor treated groups have decreased lecconarity and increased spread. And there are some representative images of these brain samples at the top, which show resting microglia in the breastfed group and the treated group, and in the middle, which is our NEC group, the more amoeboid activated microglia. And so this leads us to some exciting future directions. So first, we wanted to look at a dose response curve, specifically looking at what doses of IL-17A inhibition would be tolerated, as well as to see kind of our next steps would also be to look at rescue therapy and seeing if we can give the inhibition later on during the experimental model. And so we've started to do this with doses based off of the literature, with a low dose being 1, a mid dose being 3, and a high dose being 9, all milligrams per kilogram per day for the mice. And so we see overall, there's no differences clinically with the inhibitors improving macroscopic and clinical sickness scores. But we do see a difference in terms of histological injury scores. And so although all 3 doses result in improved histological injury, the middle dose was the best overall, indicating that there's obviously an improvement with IL-17A inhibition, but high doses resulted in a decrease in improvement. And so we'll further be elaborating our work on the dose response as well as implementing the IL-17A inhibition halfway through the model. We'll also be looking at the long-term impact of IL-17A inhibition by reuniting these mouse pups after they receive their therapy with their foster dams to look at long-term impacts of this inhibition. We'll be further examining brain injury. And we're also in the process of developing an IL-17 receptor knockout mouse to further look at IL-17 and its implications in the neck disease process. So overall, IL-17A is a promising potential therapeutic target, especially when considering some of the severe downstream complications of this disease. We know that IL-17A is implicated in neuroinflammation, and preventing those neurodevelopmental impairments from taking place is an important future study for us. Thank you for your time. I'd like to thank my lab, and I'll take some questions.
Thank you very much. Unfortunately, in the interest of time, we have to move on. Great work, and I'm pretty sure we can connect afterwards. Sorry about that.
All right, for our next talk, we have Dr. Daniel Sheech, who's coming to us from Johns Hopkins Hospital, who will be presenting adenosine supplementation protects the intestinal epithelium and reduces severity of necrotizing enterocolitis.
All right. Thank you all for being here. I'm Dan Sheets. I'm a general surgery resident at VCU, finishing up my final year in Dr. Hackham's lab up at Hopkins. We have nothing to disclose pertaining to this topic. And just, we have had a few presentations on neck today, and we all kind of study this disease. We're motivated by the families that we encounter who have had these heartbreaking loss to their children. That motivates us to keep studying and keep pushing forward. And as trainees, we definitely we build on kind of the giant leaps that the esteemed researchers in this room and came before have already made in this field. And so today what I'm presenting is kind of just to open our minds up a little bit to a possible novel therapeutic, not just necrotizing enterocolitis, but in pediatric inflammatory disease in general. But to zoom in on the intestinal epithelium and looking at the impact on the cell, what we see is a hypoxic and ischemic insult to the cell, which causes the cell to undergo apoptosis, releasing these large ATP stores into the extracellular space. And now we think of extracellular ATP to be pro-inflammatory, so the body quickly tries to break this down through different ectonucleosidases, specifically CD39 and CD73, into adenosine, which is thought to be anti-inflammatory. And this extracellular adenosine can work in a few different ways by binding to different adenosine receptors on the cells, or to be transported intracellularly through different transporters where it has different functions, such as being built up to ATP, allowing for increased ATP stores within the cell. So our hypothesis is that supplementation of oral adenosine to the intestinal epithelium will protect against the TLR4-induced mucosal inflammation and epithelial cell death seen in neck. So to start looking at this, we used cultured enterocytes that were co-treated with a mixture of the TLR4 agonist, the lipopolysaccharide, as well as a long-acting adenosine analog, NECA. The half-life of adenosine is about 4 seconds, so using this longer half-life, longer-acting analog has about a half-life of 4 hours. And so we co-treated the cells together, looked at pro-inflammatory cytokines, and also NF-kappa B assay, which Dr. Dus had talked about a little earlier, where the activation of NF-kappa B causes translocation into the nucleus of the cell to go on to produce further pro-inflammatory cytokines, so we can just stain for NF-kappa B and see its location within the cell. And what we see is when we co-treat these cells with LPS and the adenosine analog, that we see a reduction in the amount of translocation into the nucleus of NF-kappa B. And this goes along with what we see in the pro-inflammatory cytokine profile, in which the TNF-alpha is significantly decreased when these cells are co-treated with adenosine and LPS. So then we move to our neck model, in which we added oral adenosine to each of the formula feeds that we gave during the entirety of the neck model. And what we found is that we see a significant decrease in the expression of TLR4 with the addition of oral adenosine into these feeds. We also see, to go along with that, a decrease in pro-inflammatory cytokines IL-6 and TNF as well. And to corroborate this, looking at the histological sections of the ileum, we see that with NEC we get a pretty severe disruption of villus architecture, and that by the addition of the adenosine to the formula, we get protection of that disruption of the villus architecture, as well as nice tight junctions preserved throughout the entirety of the villi, even through the tip. So the key takeaways is that supplementing oral adenosine has shown promising results in protecting against TLR4-induced mucosal inflammation and epithelial cell death in NEC. The administration of this long-acting adenosine analog notably reduced inflammation by inhibiting the translocation of NF-kappa B and IEC6 cells and decreased the expression of TLR4 and pro-inflammatory cytokines in NEC models, and that oral adenosine supplementation could be a novel and effective therapeutic strategy to mitigate the severity of NEC in premature infants, potentially reducing the morbidity and mortality associated with this condition. So thank you so much, and I'll be happy to take any questions.
We made up a little time, so if anybody has a question, be happy to take it.
I have a quick one. So adenosine, I don't know if I remember well from my residency times, you push it, it stops the heart, right? And so what are the side effect panel or profile of adenosine that you actually ingest? And how it's a short half-life, at least when you inject it. And so what happens in the gut, and what do you anticipate?
So it's a great question. So when I initially thought about studying this, that was the first thing that went through my mind. If I give this through IP injection, is the heart of these pups just going to stop? And now I haven't directly measured the bradycardic response that giving this has done, but I've had zero mortality with oral adenosine feeds, whether I do tenfold more or tenfold less than the dose that I presented today. It may cause some bradycardia, but again, it hasn't led to any mortality directly from administration. IP as well, administer. I haven't seen the protective effects. They're not as noticeable through systemic administration, through IP administration, than with oral. So, but again, even with that and these low doses, I haven't had any bradycardic, severe bradycardia leading to direct death or that.
And what's the half-life of it, do you think? Do you look at?
So that the known half-life of adenosine is 4 seconds if you give it. It's actually pretty difficult to measure adenosine in general, just because of how quickly it either gets further broken down to inosine or built up to ATP. I know that studies have tried to measure adenosine levels in breast milk as a potential way that breast milk is protective. Again, it is challenging. Even if you have all of the inhibitors needed there, it's still quick. So I've tried using just regular adenosine through oral administration, and I haven't seen the protective effect. So it must be degraded too quickly before it get down to the ileum to show the protection that the long-acting shows.
I'm not a biochemical engineer or medical engineer, but do you know if any bacteria are making adenosine, so you could collaborate with your colleagues?
That's a great question. I don't know, but that's a good thing to think about. We have been in talks with some of our engineers at Hopkins, and we've been able to actually crystallize the molecule, so that way you can just give adenosine in a crystallized version that can get broken down over time along the GI tract. But you bring up a good point about the bacteria. I'm not sure.
I'll tell Dr. Hakan
Yeah.
that I didn't have that idea. No. Great work. Any other questions? Thank you.
Thank you.
Our last presentation is by Dr. Ott, who's going to talk to us about the enteric neurotransmitters neuromedin U reduces inflammation in Hirschsprung's-associated enterocolitis through activation of group 2 innate lymphoid cells. Dr. Ott is from the Massachusetts General Hospital in Boston.
Good morning, and thank you for the opportunity to present our work. We have no relevant disclosures. Hirschsprung-associated enterocolitis is the most severe complication and leading cause of death in patients with Hirschsprung's disease, both before and after, and can affect patients both before and after pull-through surgery, with an incidence of 25 to 42% post-definitive surgery. To date, there are no targeted treatments for HAEC, with standard treatment just involving rectal irrigations and oral or IV antibiotics that come with their own morbidity. Mucosal neuroimmune signaling may represent a novel therapeutic target for the prevention or treatment of HAEC, given that recent studies demonstrate the ganglionic bowel is abnormal in murine models of Hirschsprung's disease. And furthermore, enteric neuronal stem cell therapy, which is under investigation by our group and others, may be further optimized to address both dysmotility and immune dysregulation in Hirschsprung's disease. So group 2 innate lymphoid cells are a population of innate immune cells that reside along mucosal barriers, and they serve to modulate inflammation. Specifically in the intestine, ILC2s participate in crosstalk with enteric neurons, specifically cholinergic enteric neurons, that release the neurotransmitter neuromedin U, that then can stimulate ILC2 proliferation and production of their signature cytokines IL-5 and IL-13, which then have downstream immunomodulatory effects, activating other immunosuppressive immune cells such as Tregs and M2 macrophages. And so our hypothesis was that in the setting of an abnormal enteric nervous system in Hirschsprung's disease with fewer cholinergic neurons, we hypothesized that you're going to have lower levels of neuromedin U, which then could lead to a relative lack of ILC2s and perhaps also enhance inflammatory immune cell infiltration. And so we quantified immune cell populations in the colon of P14, EDIN-RB knockout, our murine model of Hirschsprung's disease, and wild-type littermates at P14 using fluorescent immunohistochemistry. We also looked at neurotransmitter receptor expression in the colon to confirm that this was an appropriate therapeutic target in adult wild-type mice using single-cell RNA sequencing. And then finally, P14 to P16 knockout mice were treated with 1 dose of recombinant NMU at 1 microgram per gram body weight, or isovolumetric saline control. We sacrificed mice at 72 hours post-injection and assessed HAEC severity as well as immune cell populations in the colon using histology and fluorescent immunohistochemistry, flow cytometry, and quantitative PCR. For our histopathological scoring, we used a previously validated murine enterocolitis severity score, taking into account both depth of inflammation and severity. And so, firstly, when we looked at our P14 EDIN-RB mice, we saw a significantly greater green fluorescent CD45 immune cell infiltration at P14 as compared to wild-type littermates, even before the onset of clinical illness, consistent with spontaneous onset enterocolitis. Next, when we quantified neutrophils using the red fluorescent antibody against S100A8A9, we again saw an enhanced infiltration of neutrophils in the colon of our P14 knockout mice as compared to wild-type mice in which there are relatively few neutrophils. Next, when we quantified ILC2s in the colon utilizing staining for KLRG1 and CD3, so ILC2s will be positive for green fluorescent protein but negative for purple. We again saw a reduction in ILC2s in the colon of our EDIN-RB mice as hypothesized. Then when we compared neurotransmitter receptor expression in various immune populations in the colon of adult wild-type mice to confirm that the findings in the small intestine, that the neuromedin U receptor is specific to ILCs, to confirm this in the colon, we used single-cell RNA sequencing and found that neuromedin U receptor 1, NMU's cognate receptor, is predominantly expressed in ILC populations, but to lesser extents in macrophages and very low levels in other immune and non-immune populations. And so when we compared mice that were treated with neuromedin U versus isovolumetric saline, we found that at 72 hours post-injection, our PBS-treated mice had significantly greater neutrophil infiltration, as indicated by Ly6C high, Ly6G high cells of flow cytometry, and that neuromedin U treatment attenuated this neutrophil infiltration by approximately half. Next, when we looked at ILC2 numbers to confirm that our treatment was having an effect on this population, we saw that neuromedin U treatment restored the levels almost to wild-type levels whereas our PBS-treated mice, their numbers of ILC2s remained low. And finally, to confirm that not only was it proliferation of ILC2s, but also their activation that was contributing to this improvement in inflammatory cell infiltration, we performed quantitative PCR on full thickness colon samples from these mice and found that when we looked at expression of ILC2's signature cytokines IL-5 and IL-13, we saw an overall trend towards enhanced expression in our NMU-treated mice as compared to saline, although this did not reach statistical significance. And finally, when we looked at CD45 infiltration in these same mice 72 hours post-NMU injection, we see a marked reduction in immune cell infiltration following Neuramin U treatment as compared to saline. And then to kind of hit the final bar of checking for histology, checking by histology for colitis severity, at 72 hours post-NMU injection, we saw a trend towards improvement in enterocolitis, although this did not reach statistical significance and did vary significantly between animals. Although of note, the only mice to have complete resolution of their enterocolitis with a score of 0 were those in the Neuramin group. So in conclusion, we show that eating RB mice have fewer colonic ILC2s. It's likely due to impaired enteric neuronal signaling, given the relative lack of cholinergic enteric neurons. Neuramin U injection, which can very specifically stimulate colonic ILC2s to proliferate and produce cytokine, can attenuate CD45 immune cell infiltration and pro-inflammatory neutrophil infiltration, and restores the ILC2 population to wild-type levels. And neuramin signaling through ILC2s may represent a novel therapeutic target for the treatment of HAC. I'd like to thank my mentor, Dr. Goldstein, the other members of our Goldstein lab, and our sources of funding. I'd be happy to take any questions.
Thank you. Dr. Piero?
Agostino Piero, Toronto. Thank you very much. Congratulations, excellent work. I wanted to ask you if you look where the NMU activity is actually targeting the colon, is in the ganglionic bowel or in the aganglionic bowel. We have been using the same mutant and finding differences in relation to where the ganglion cells are present or not.
I see. That's a great question. So we've looked at both ganglionic and aganglionic regions in our knockout mice, and we administer our NMU IP, which is a systemic administration, and so should target the full length of the colon, and we see a trend towards improvement in inflammation in both.
Okay, because this is important because you could have enterocolitis before the pull-through, or you could have it after the pull-through.
Absolutely.
Thanks.
Thank you.
Last questions, Dr. Nasser?
Great work, Issam Nasser from Johns Hopkins. Are any plans to look at human specimens? Because you'll have a very nice control. You usually take, as you know, 5 centimeters proximal to the transition zone, and then you have a nice control. Look at ILC2s, quantitate, do some flow. I would be curious to see what this looks like in a human model rather than a knockout mouse model. I think that would make a huge difference. Any plans? Have you looked at human specimens, and then correlate clinically with patients that develop enterocolitis down the line?
It's a great question. That's not something we've done yet, but we are really lucky to have human samples from Mass General for Children through a biorepository. And so I think that's a great point, something to check as well, that this applies to human patients as well.